Good afternoon, everyone. So we're very pleased to have you joining us today. And my name is Sophia Autry, the Deputy Division Director for the Division of Community and Population Health. And I'm looking forward to a wonderful event with you. So a few reminders before we get started. The compliance slide and the recording from today's session will be posted to the QIO program website, so be on the lookout for that. So we'll also post the link of that website to the chat for those of you that are not familiar with the QIOprogram.org website. During the open discussion and Q&A period, please keep in mind that we will get to as many questions and comments as time permits. But if there are any unanswered questions, we will address those as well after the event and post them to our website. Along with our speakers today, we also have our CDC colleagues available to answer questions. So I want to thank our colleague, Dr. Namali Stone, for always being available and available to assist us. Slides and resources for this event can be found on the QIO program website, and that is QIOprogram.org/nursing-home/trainings. And we'll also put that link in our chat. Please also note that we will have a post-event survey that will be shared via the link in the chat. So please complete the survey and let us know how we can make these and other training opportunities better for you. So next slide, please. Thank you. So I'd like to introduce our speakers for you today. We have four wonderful and impressive speakers. Eli DeLille, he is the infection preventionist at Health Services Advisory Group, or HSAG. Deb Smith, she's an infection preventionist at Health Quality Innovators, HQI. Dr. Kimberly Rask, she is the Chief Data Officer at Alliant Quality. And Susan Purcell, she's the Project Director at TMF Quality Innovation Network. Our first speaker will be Eli DeLille from HSAG. Mr. DeLille serves as an infection preventionist with more than 16 years of experience in the healthcare industry with expertise in quality improvement, analysis, and implementation of performance improvement, patient safety initiatives, and direct patient care. Mr. DeLille earned a master's degree in nursing from Marshall University. He is certified in infection control and is a fellow with the Association of Professionals in Infection Control and Epidemiology. I would now like to turn the call over to Eli DeLille. Eli, the virtual floor is yours.
Thank you, Sophia. I appreciate the introduction, the opportunity to be here today. Next slide, please. I'm going to cover what establishing an infection prevention program would entail, as well as conducting ongoing infection surveillance in the nursing home. Next slide. Some key elements of infection prevention include developing a system for preventing, identifying, reporting, investigating, and controlling infection and communicable diseases for all residents, staff members, and visitors. And I've been doing this work now for over 8 years, and I can tell you that it's the most challenging time I've ever seen for the profession of infection prevention. And hopefully the tools and resources and the information the team shares with you today you find valuable. We want to share how to establish goals and priorities for your program, and we have some actionable tools and resources for you to use to do that. We're going to show how to plan and implement strategies to achieve the goals that we're going to set, as well as monitor compliance and respond to any identified issues that you run across. Next slide, please. I can't really talk about infection prevention without talking about the importance of adequate training for somebody new to this profession. When I went into infection control, I'd been a nurse for over 10 years at that point, and quickly discovered that just because I was a knowledgeable nurse and knew a lot about trauma and emergency room, I didn't know how to be an effective infection preventionist. And there's training like what the CDC has produced that's going to help your brand new infection preventionists or seasoned ones get a better idea of how to adequately do this role and make them more effective in what they're doing as well. It's a self-paced training. It's designed for working staff members. It's a series of modules as short as 20 minutes long, so that even the busiest infection preventionists can find time to go through the training. Next slide, please. Now, as great as the CDC training is, it doesn't necessarily prepare the infection preventionists to work on their own within a facility. So at HSAG, we're fortunate to have 50 plus years of combined infection preventionist experience. So what we did was we created an infection prevention orientation checklist. So this is a simplified format. Maybe you're a nursing home right now that is still COVID naive and you're preparing for COVID or to fight COVID from coming into your building. But there are other areas that infection prevention is being split between 2 or 3 staff members. And you want to make sure that each one of those staff members is adequately prepared to answer questions. So what this form is intended to do is make it so that you don't confuse staff by providing different guidance based on the person that they're asking the questions to. And this is going to be available with all the rest of the resources I'm sharing today via the QIO website, and it's also available on our website as well. Next slide, please. Now that you've gone from a reactive state to a more proactive, you start to get that knowledge base. Hopefully you're that COVID naive facility and you just want to be as prepared as you can, or you may be dealing with an outbreak situation. And the CDC has developed an ICAR assessment initially designed for public health professionals, but what we've discovered as a company is that it's the best self-assessment a nursing home can do to look to see if they have gaps in their prevention or control activities around COVID at this time. It's a 13-page document. It covers everything from the 5 areas that you see here, from keeping COVID out of the facility to identifying and managing severe illness if it does come into your house. So I'm not going to cover this as in-depth as what I normally will, because the other speakers on this call will be giving additional detail on each one of these items. Next slide, please. Once you've got that assessment, you've got the fundamental knowledge that you need, you're likely going to have some areas of opportunity. And unfortunately, there's just not enough time in the day to go after every single item. You have to prioritize where you're going to spend your time. And working with our partners in the nursing home across the states of California and Arizona, we've discovered that this approach is very effective. It's easy to incorporate into your QAPI plan. You have metrics, you have the findings that contributed to potential concerns, time frame of completion, ownership, and then also outcome measures with your NHSN data, as well as process measures. So I can't stress enough how important going out and auditing hand hygiene, isolation compliance, source control, environmental cleaning, and a host of other items is right now. Tracking and trending this information will help you keep a control of COVID within your particular skilled nursing facility. And this resource, as well as many others around infection prevention, are also going to be made accessible to this group. Next slide, please. So once you have your action plan developed, as a new infection preventionist, I made the mistake of trying to roll something out without getting feedback from my partners. So I was telling people what to do, but I wasn't necessarily giving them the why behind it. And with such a fast-moving, dynamic situation right now, it's extremely important to make sure that we're educating the staff regarding why you're asking them to do something, not just what you're telling them to do, because what you'll find is they're a lot more engaged. And a new infection preventionist, or any infection preventionist, can't be everywhere all the time. We need advocates out there, champions that are pushing patient safety, resident safety, and the right way to approach infection prevention. And having your team provide feedback on the plan is going to be the best way to do that. You want to empower your staff so that they can speak up if they identify a concern, and even speak up to one another if they see somebody that needs to be counseled around the way they're taking off their personal protective equipment or wearing their mask below their nose, or a host of other seemingly minor infection prevention lapses that could lead to horrible outcomes with our resident population, especially when we're seeing mortality rate in some instances as high as 50% and higher. Next slide, please. All the resources I mentioned so far today are all available here, as well as several others. As you're looking at your findings from doing an ICAR assessment, you may have so many that you have to risk adjust them, and there's even a risk assessment that you can use for that. And we're happy to answer questions if you do have any questions around like the specific resources we have here. Next slide, please. And then one more. So I'm fortunate enough, IPRO couldn't be here today, so I've been asked to present their information around implementation strategies around COVID-19 surveillance as well as early detection, and I want to thank them for this opportunity. And go ahead and go to the next slide, please. And they focused on CDC's 3 key steps, which is keep COVID out. The easiest way to control something is prevent it from ever happening within your facility. And we very much hope that you're COVID naive at this point, that you have your source control, that you're screening appropriately, that you have your transition unit available. But in the event that you don't, we need to make sure that we're detecting cases quickly, and that can be through a variety of ways, through test-based strategies or symptom-based. And then all the strategies we're going to talk to you about today really come together to stopping transmission of COVID-19 in its tracks, which is our ultimate goal. Next slide, please. So these are tips from partners that ICAR has on the East Coast, and we have seen it just reiterated here on the West Coast as well, especially in the states of California and Arizona where we operate. And the importance of adequate wellness checks and screening, I can't reinforce enough. To do this just cursorily or not ask the necessary questions is a good way to miss a potentially symptomatic staff member going and working and unnecessarily exposing. As I mentioned before, a seemingly simple lapse of having your mask down, not washing your hands, can have very dire consequences. Also, with the staffing concerns that are coming up and the rapidness that symptoms can develop, perhaps checking more frequently than just at arrival to your shift could become important, especially for those people that are working 6, 12, 18-hour shifts. And then you also want to assess at the end of your shift to make sure that if you are feeling ill at that point, there may need to be steps taken in order to cover your shift proactively. I know at least in California, we've experienced several evacuations due to COVID and staffing issues. We'd never want that to happen. But of course, resident safety is of paramount concern when these issues do develop. And then another issue that we've heard about is when multiple staff members are arriving, it does take time to do these screens adequately. You want to make sure that you're staggering your shift starts so that we are maintaining that social distancing, which is another incredibly important infection prevention technique around COVID prevention. Next slide, please. So some additional tips from providers is we know that staffing is an issue, and we want to make sure that we're not pressuring staff members who are symptomatic and positive for COVID-19 to come back to work too early. Once again, this can absolutely negatively impact your facility and your resident population. Thinking outside of the box about how to cover your shifts if necessary, going to 12-hour shifts from 8-hour shifts, using that extra staff members to cover those additional requirements. Agency staff members is something that we're hearing used widely, at least in our states of interest, as well as on the East Coast. And you just have to be careful because if these staff members are working in more than one area, they can pose a risk, especially if they're working at 2 outbreak facilities and then they're coming to your COVID-naive facility. So you definitely have to work with your local and state health departments to make sure that if this is happening and there is no choice, that we're doing it as safely as possible. And then prepare for staffing shortages. One great thing we've heard about in California is where volunteer retired nurses and infection preventionists are going in and helping on the front lines in nursing homes that are at risk right now. So work with your local and state health department to really know what those resources are. Next slide, please. Some additional tips from our providers is the importance of communication. We know that there's requirements from CMS on how to communicate with COVID, but it's so important right now to share your strategy with your frontline staff, to let your providers know, to let your community partners know, as well as your resident families and your residents. It's a very scary time for everyone, and we are blessed with incredible technology right now that we hear people using everything from Zoom webinars to keep everyone updated to even a facility in Northern California that created a VIP lounge, which is a visitor infection prevention lounge, completely segregated away for their more ill residents to interact with their family members in a safe way. And when I say ill, I mean non-COVID illness. And then you want to limit access to your facility. We all hear about the visitor restrictions and how difficult that is for the residents not to see their families, but we have many people entering our buildings that we don't always pay attention to. The vendors bringing food and other items, medical equipment. These are somebody that are going into multiple facilities and also pose a significant risk to your facility. And then have a clear return to work policy. We mentioned before the importance of making sure that you don't have staff working when symptomatic. Well, if they are off work and you're in a shortage, you want to make sure you know when they can come back safely and that you're not pressuring them to come back too early. Next slide, please. And ultimately, we want to detect those cases quickly. So if your keep COVID out strategies have not been effective, then you want to make sure that you immediately begin trying to detect cases as quickly as possible. And this should be in conjunction with your Keep COVID Out. That may include taking more frequent vital signs. We know that it is very subtle in the elderly population, and COVID can present in many different ways. So change in appetite, change in behavior, decreased activity are all things that really should be raising a red flag with our staff as well as with our ancillary staff. Mid-shift huddles is a great way to get a picture of how things are going. We have heard from multiple nursing homes that tell us that they started out okay. An hour later, they had a low-grade temperature. 4 hours later, they were being transferred to the hospital in respiratory distress. That's the reality of how quickly this can really happen. So having more frequent touch points with your team is really imperative during this difficult time. And it all comes back to the basics. I've been a nurse now for a number of years, and those assessment skills, monitoring for those subtle signs and symptoms, is so important right now. And empowering your staff, like I mentioned in the first portion of the presentation, if they have a concern, they need to feel comfortable come to you immediately and saying, you know, I really feel like COVID may be a concern with this particular resident. Next slide, please. And finally, stopping transmission. The things that all the speakers today are going to talk about with you, from washing your hands to ensuring that the residents are being kept clean, washing their hands, that we're cleaning things appropriately, all come together to stopping COVID transmission in its tracks. And that concludes my portion of the presentation. There's another slide with resources from IPRO. And then I want to thank, on the next slide, Marguerite and David for the opportunity to present their information today, and turn it back over to Sophia.
Thank you so much, Eli. Next slide, please. Okay. First, before we go to the next speaker, as a reminder, we will have a Q&A session at the end of the call. However, you are welcome to submit your questions at any time during the presentation. Just click on the Q&A tab at the bottom of your screen. Our next speaker will be Deb Smith from Health Quality Innovators. Ms. Smith has more than 20 years of experience as an infection preventionist, registered nurse, and ASCP registered microbiology technician. Ms. Smith is a member of the Virginia chapter of APIC. Ms. Smith holds her certification in infection control, and she is a certified professional in healthcare quality. Take it away, Deb.
Thank you, Sophia. Next slide, please. So my topic today for training is cohorting as a core intervention of an infection prevention program, and it's currently being utilized during the COVID-19 pandemic. Next slide, please. The goal of cohorting or isolation is to prevent the transmission of microorganisms from infected, colonized, and/or asymptomatic residents to other residents, staff, or visitors who may in turn transmit them to others or become infected or colonized themselves. Residents infected or colonized with the same infectious agent can be cohorted together to prevent spreading that infection to other non-infected residents. Staff are also included in cohorting during outbreak situations like the COVID-19 pandemic to a specific cohort of infected residents, which will further limit the risk of spreading infection in the facility. Next slide, please. To contain disease during the COVID-19 pandemic, the CDC outlines a plan for nursing homes to create a COVID care unit in their facility that can be dedicated to care for residents with confirmed COVID-19. This COVID care unit should be physically separated from the rest of the facility and be in place before the first suspected or confirmed COVID-19 cases. The COVID-19 care unit can be a dedicated floor, unit, or wing in the facility, or just a group of rooms at the end of a unit separated by a barrier that will be used to cohort residents with COVID-19. Nursing staff should be dedicated to work on this COVID care unit when it is in use. If ancillary staff cannot be dedicated to the COVID care unit, they should be restricted from entering the unit. Next slide, please. There should be posted signage at the entrance to this COVID care unit instructing everyone who enters the unit to wear eye protection and an N95 or higher level respirator at all times while on the unit. Following the CDC's PPE optimization strategy, a face mask can be used when respirators are unavailable, but remember, cloth face coverings are not considered PPE and should not be worn when PPE is indicated. Gowns and gloves should be added when entering resident rooms to perform resident care. Provide infection prevention training that includes the use of and steps to properly put on and remove all recommended PPE. Resident care equipment should be assigned and dedicated to the COVID care unit. Cleaning and disinfection of shared equipment should be performed between resident care, and that equipment should not leave the COVID unit. Next slide, please. You'll need to assess your on-site and remote staffing capabilities to ensure that you have adequate clinical and non-clinical staff with the required training, skills, and competencies in place for staffing this COVID care unit. These assigned and cohorted staff should not work across other units, floors, or facilities. If your facility doesn't have enough ancillary staff to dedicate to the COVID care unit, nursing staff may need to perform things like housekeeping and dietary tasks, so they'll need extra education in these areas. Whenever possible, it's recommended that nursing homes integrate consistent assignment of staff to specific residents, with the goal being to decrease the number of staff and resident interactions. Staff access between the COVID unit and then the rest of the facility should be limited as much as possible, and this can be accomplished by things like providing a separate entrance or dedicating break areas and supply rooms for the COVID care cohorted staff. Next slide. Keeping the resident and the family informed of the cohorting process is the first step in managing a resident with COVID-19 symptoms. Residents in the facility who develop symptoms consistent with COVID-19 should be prioritized for testing and immediately moved to a single room pending the results of that testing. They should not be placed in a room with a new admission, and they shouldn't be moved to the COVID care unit until they are confirmed to have COVID-19 by testing. The roommates of these residents with COVID-19 may have been exposed, and they should be considered infectious and moved to a single room or observation area. You can cohort potentially exposed residents in an observation area only if single rooms are not available. Residents with known or suspected COVID-19 should be cared for using all recommended PPE, which includes the use of an N95 or higher level respirator, eye protection, gloves, and a gown. Next slide. If your facility is receiving new admissions or readmissions who have been confirmed to have had COVID-19, you'll need to carefully assess each resident for placement in your facility. If the criteria for discontinuation of transmission precautions has not been met, they would be admitted to the COVID care unit. If they have met the criteria for discontinuation of precautions, they can be admitted to a regular unit. When admitting residents with unknown COVID-19 status, they would not be cohorted on the COVID care unit, but they would be placed in a single room or in a separate observation area so the resident can be monitored for evidence of COVID-19. During this time, staff should wear all recommended COVID-19 PPE when caring for these residents. Residents can be transferred out of the observation area to the main facility if they remain afebrile and without symptoms for 14 days after their admission. Next slide. You will continue transmission precautions and cohorting for all symptomatic and asymptomatic COVID-19 positive residents until criteria for discontinuation is met. The criteria on this slide are the CDC recommended strategies for discontinuation of precautions for both symptomatic and asymptomatic residents. It's important to remember, though, that if your state or local regulations are stricter and include a longer duration, you must follow those stricter regulations. Also, if a symptomatic resident declines or is unable to be tested, you'd continue transmission-based precautions until the symptom-based criteria are met. Next slide, please. Finally, contaminated healthcare surfaces play an important role in the transmission of microorganisms, including COVID-19. So therefore, appropriate cleaning and disinfection of surfaces and equipment which residents and staff touch is necessary to reduce exposure and minimize the risk of cross-infection from one person or object to another. Environmental cleaning during COVID-19, especially on the COVID care unit, should be enhanced and include at a minimum daily room cleaning of all high-touch surfaces more frequently. You also need to refer to the list of approved disinfectants to assure that your facility is using the right product the correct way, and pay close attention to those recommended dwell times. Next slide, please. So thank you so much for your time today. This is my contact information, and the next slide, I believe, is how to contact HQuinn and the end of my presentation. So I will hand this back over to Sophia. Thank you.
Thank you so much, Deb. Next slide, please. Okay, so our next speaker from Alliant Quality is Dr. Kimberly Rask, Chief Data Officer. Since 2008, Dr. Rask has provided clinical and analytical direction for economic evaluations, patient safety initiatives, and quality data reporting. A primary care physician and healthcare economist, Dr. Rask also holds academic appointments with her research focusing on quality improvement and outcomes measurement, with particular attention to rural and underserved populations. Dr. Rask, you are welcome to begin.
Thank you, Sophia. Next slide, please. So today I'm going to focus on 3 aspects of the clinical care for COVID-positive residents. First, I'm going to talk a little bit about the different disease trajectories that we're seeing in people who have COVID-19. Secondly, we're going to talk about the appropriate plans that you want to have in place to make sure that treatment plans align with the residents' goals and preferences. And third, talk about working with your medical directors to make sure that you have the necessary medications readily available when they're needed. So first, let's talk a little bit about the disease trajectory. COVID is new, so we continue to keep learning more about it every day, every week. As you all know, we think that the symptoms are most likely to develop between 2 and 14 days after someone has been exposed to another person with COVID-19. And early on, we focused a lot on the fever, chills, cough, shortness of breath, respiratory symptoms like sore throat and runny nose. And over time, kind of noticed there were a lot of other symptoms that we were also seeing in people who had COVID: the headaches, the nausea, vomiting, diarrhea, fatigue, muscle aches, loss of taste or smell. And what has kind of evolved is an early perspective that COVID-19 was really a respiratory disease or a virus that attacked the respiratory system. We're now thinking about it as a virus that affects blood vessels. And given that, we're seeing a lot of impact on other organs that we didn't necessarily focus on early on. And that's important as you try and monitor the health of the residents in your facilities, those that you know have COVID-19 or those that you suspect that might have it. There are some residents who will be COVID-19 positive and have absolutely no symptoms. There are some that will have minor symptoms and they'll get better, and they'll be the typical symptoms that we've come to expect between the respiratory system and the GI tract. What makes this more challenging is that there are many people who will have minor symptoms, and then very quickly decline clinically and proceed to respiratory organ failure. As one of the earlier speakers noted, it's surprisingly fast how that can happen. And for that reason, the Centers for Disease Control is really recommending that residents be monitored more frequently than is typical to be able to make sure that vital signs, symptoms, oxygen saturations are stable and not changing, and if they are changing, to be able to identify early that something is going on and that the patient's status has changed. Next slide. The other thing that is challenging about this is that many residents will often not have the typical symptoms and may really have what sometimes we refer to as the dwindles, or just kind of generally nonspecific change in status, just not doing well, maybe more tired than usual, maybe not as alert as they normally are. They may stop eating or drinking as much slowly over several weeks. And picking this up is really dependent on having staff really know their residents and recognize that Mrs. Jones isn't usually like this. Something is different. We really can't count on identifying the classic symptoms of COVID. We've got to be able to pick it up in residents who have very nonspecific, just not their usual selves. And in this chaotic time, that can be difficult with residents being moved from one unit to another, with staffing changes. So if you can't have a staff who is consistently seeing the same resident, then you need to have processes in place so that those staff can communicate effectively to make sure that you can pick up those changes in status. The other point is, as we are realizing that COVID-19 is kind of a blood vessel disease, we're seeing a lot of stroke, blood clots, neurologic symptoms. So again, another thing to think about in that nonspecific altered mental status, COVID-19 has got to be in the picture. Next slide. Okay, now let's think about making sure that the appropriate plans are in place given a resident's goal and preferences. Advanced care planning is, of course, what we're talking about, and something that is important for all residents. But it's particularly important in this COVID era, given, as we have said, that so many residents may go from very minor symptoms to suddenly being critically ill. And having those preferences documented in advance will give your staff and your facility the ability to be able to meet those resident needs. And know in advance what kind of plan to put in place. The big question that it often comes down to is whether or not a resident wants to be transferred to a hospital if their symptoms worsen. And in thinking about this, what you may want to weigh is kind of what services are available in your facility versus what services are available in a hospital setting. As you know, currently we don't have any very effective treatment for COVID-19. What we're doing is providing supportive care. The main method of supportive care that's available in a hospital that might not be available in a facility is a ventilator. The challenge with the ventilators for many of our older residents is the data that's coming out of New York and other places point to a really high mortality rate, often in excess of 80% for residents who are 80 years or older and placed on a ventilator, or even younger than 80 if they're an older adult with underlying medical conditions. Mortality rates have been running 75 to 80%. So this is really something for families and residents to be thinking about as they think about whether they want to stay in the facility or be transferred to a hospital. Next slide. And then finally, what you want to do is make sure that you're working with your medical director is to have any necessary medications available in a timely manner. So you may consider standing orders for acetaminophen or Tylenol, supplemental oxygen, and making sure that your staff knows how to appropriately position patients to residents to make breathing easier. You might want to consider discontinuing any non-essential medications. And if possible, change nebulizers to meter dose inhalers so that you don't have as many aerosols generated that might put staff at risk for spreading COVID-19. One aspect that sometimes also has to be planned in advance is making sure that you have access to concentrated opioids for relief of shortness of breath. Often it's best if they're given intravenously, and you want to be sure that those medications are readily available, and that's not something that you would have to wait for several hours and leave a resident in discomfort. For more information about this and other specific measures for evaluating and managing residents with symptoms of COVID-19, I encourage you to go to the Centers for Disease Control's website, which is on this slide, which has a lot more details and is updated frequently as what we know about COVID-19 keeps changing. Thank you, and I'll turn it back over to Sophia.
Thank you so much, Dr. Rask. Our final speaker for today is Susan Purcell from TMF, Quality Innovation Network. Ms. Purcell has been a registered nurse for 34 years, working in critical care, home health, hospice, and nursing management. Ms. Purcell has been with the QIO for over 16 years, leading quality improvement projects in case review, nursing home, hospital, and outpatient settings. Susan, the floor is yours.
Hello, everyone, and thank you, Sophia. And thank you to Telegen, the Quinn QIO, who originally authored this presentation today. Next slide, please. The objectives of this PPE presentation is to help you with the why and how to use PPE and to give you links to resources that could be helpful. You'll see that I've included numerous links throughout the slides for more in-depth information, and there will be information in the chat about attaining the slides. Next slide. PPE is specialized clothing or equipment worn by an employee for protection against infectious materials. Next slide, please. We use PPE to protect ourselves, our residents, and others in the process of performing care, including protection from dangerous or infectious substances. Next slide. Listed here are types of PPE commonly used by healthcare providers to protect themselves, residents, and others when providing care. Gloves are the most common type of PPE that's used in healthcare settings. All of these serve to keep us safe. Next slide. Based on the CDC guidelines, PPE is to be used every day by all healthcare personnel to protect themselves, residents, and others when providing care. This also includes activities personnel, environmental services, dietary, administrative staff, hospice, repairmen, basically anyone who's going to be in the clinical area. There are instances where residents must wear PPE for protection, including such as attending doctor's appointments. More detailed information is available at the CDC link provided here under the tab Infection Control Guidance. Next slide. PPE must be donned correctly before entering the resident area and must remain in place and be worn correctly for the duration of work in potentially contaminated areas. PPE should not be adjusted, such as retying gowns, adjusting respirator or face mask during resident care, and must be removed slowly and deliberately in a sequence that prevents self-contamination. Have a PPE buddy system in case assistance is needed. A step-by-step process should be developed and used during training and during resident care. Next slide. For more information on the proper use of PPE, I highly recommend this CDC link. There are posters in both English and Spanish that can be used for staff education, as well as videos for educational purposes. I will go over some of their guidance now. Next slide. Standard precautions are used for all resident care. Transmission-based precautions are used when caring for those with known or suspected COVID-19 infections. Proper donning, doffing, and use is necessary to prevent self and cross-contamination, so I will go over those in more detail. Next slide. More than one donning method may be acceptable. Training and practice using your facility's procedure is critical. This is one example of proper donning. Identify and gather the proper PPE to don. Ensure choice of gown size is correct. Perform hand hygiene. Put on isolation gowns. Tie all the ties on the gown. Assistance may be needed by your PPE buddy. Put on your N95 filtering face mask respirator, or use a face mask if a respirator is not available. If the respirator has a nose piece, it should be fitted to the nose with both hands, not bent or tilted. Do not pinch the nose piece with one hand. Respirator or face mask should extend under the chin. Both your mouth and nose should be protected. Do not wear the respirator or face mask under your chin or store in your pocket between residents. Put on the face shield or goggles. When wearing a respirator, select the proper eye protection to ensure that the respirator does not interfere with the correct positioning of the eye protection, and that the eye protection does not affect the fit or seal of the respirator. Face shields provide full face coverage. Goggles are also excellent protection for eyes, but fogging is common. Next, put on gloves. Your gloves should cover the cuff or wrist of the gown. Now you are ready to enter the resident area to provide care. Be aware of your surroundings and what you're touching. Next slide. This picture from CDC shows fully and appropriately donned PPE. Next slide. Removing PPE, also known as doffing, is equally important practice to prevent self or cross-contamination. Start with removing gloves. Ensure glove removal does not cause additional contamination of the hands. Next, remove the gown. Untie the ties or unsnap buttons. Some gown ties can be broken rather than untied. Do so in a gentle manner, avoiding forceful movement. Reach up to the shoulders and carefully pull the gown down and away from the body. Rolling the gown down is an acceptable approach. Dispose in an appropriate receptacle. Exit the room or area and perform hand hygiene. Carefully wash all hand surfaces for at least 20 seconds and don't forget the thumbs. Next, carefully remove the face shield or goggles by grabbing the strap and pulling upwards and away from the head. Do not touch the front of the face shield or goggles. Remove and discard the respirator or face mask. Do not touch the front of the respirator or face mask. Perform hand hygiene after removing the respirator or face mask and before putting it on again if your workplace is practicing reuse. Facilities implementing reuse or extended use of PPE will need to adjust their donning and doffing procedures to accommodate those practices. Again, the CDC link at the bottom of the slide has more information. Next slide. Again, an infographic from CDC with information regarding removal or doffing of PPE. Next slide. Some tips for face masks. When you put on a face mask, perform hand hygiene and put the face mask on where it covers your mouth and nose fully. When wearing a face mask, don't wear it under your nose or your mouth. Don't cross the straps or allow them to hang down. Don't touch or adjust the face mask without performing hand hygiene before and after. Don't wear your face mask on the top of your head, around your neck, or threaded through your arm. And when you remove your face mask, clean your hands and remove by touching only the straps or ties, and then perform hand hygiene again. Next slide. Again, a CDC infographic on these face mask recommendations. Next slide, please. And Sophia, I'll turn it back over to you.
Thank you so much, Susan. So now we would like to conduct an open discussion and Q&A session. To submit a question, click on the Q&A tab at the bottom of your screen and then type in your question. Please be aware we will get to as many questions as possible during the allotted time. If we do not get to your question today, we will answer the remaining questions after the event and then post those to our QIOprogram.org website. As a reminder, along with our speakers today, we have Dr. Namali Stone and Dr. Kara Jacobs-Slipka from CDC LTC team available to answer any questions as well. So I'm going to start with the first question. Angel and I will actually be doing a round robin and she will take the next question. So the first question, and I think this is for you, Susan, where they want you to address specifically the use of N95 face masks. I know you just briefly covered it, but can you go a little bit more in depth?
I'm not sure about the specifics of the KN95 mask, other than what I know is that that's developed in a different country. Namali, might you have some information on that?
Namali, if you're speaking, you may be on mute.
Yes, hi everyone. Sorry about that. So I think the first thing to say about respirators is that when they are NIOSH approved, that comes with a certain expectation of protection levels. We know that there are some non-NIOSH approved respirators that can meet standards when we are in a crisis situation and we don't have enough available respirators that are accessible. And when working with or looking at evaluating KN95 respirators that may be from international manufacturers, we do have some information on our website that gives you some considerations if you're looking at purchasing or trying to access suppliers from another country. Thanks.
Thank you, Namali. Our next question is, and this may be for CDC as well, if there is not dedicated nursing staff available, would the recommendation be to transfer the patient out of the SNF?
Hi, so this is Namali again. I'm not sure if I know exactly the circumstance. If for example, a center isn't able to completely separate a group of caregivers to work on the COVID unit, we know that that can be a challenge sometimes with staffing shortages. The goal is to be able to, for the shift, not have anyone working on the COVID positive units crossing back over into any of the other units and floors of the building and not really, interacting in common areas. You're trying to create sort of a separate space for those caregivers. So we have talked to centers that aren't able to dedicate a team exclusively for their COVID unit. In those circumstances, we ask that individuals are dedicated to that unit for the shift that they're working on that day, and that they don't work anywhere else in the center. Thanks.
Thank you, Dr. Stone. So we have another question here about, actually there are two questions, but I'm gonna read the first one. Is there any evidence that a recovered COVID person can be reinfected within the same flu season? And are there any concerns about placing the newly admitted recovered COVID resident on a positive unit for 7 days to confirm recovery? And that can go to anyone.
Hi, this is Namali from CDC. I think we don't know exactly what to expect with relative protection following COVID infection. And so at this point, we are very conservative in our approach. And for example, recommend that if an individual who is recovered starts to develop signs and symptoms that are concerning for COVID, they be reevaluated for that possibility in addition to other. And I do think it's a really important issue to think about how we are going to address potential for co-infection with influenza, especially as we come into the fall. So I think centers should be thinking through their respiratory testing options and trying to make sure that they have access to both COVID testing and testing for other respiratory viruses that can also circulate. As far as the second question about placement of an individual who is recovered on a COVID unit, that is a reasonable strategy if there's space on the unit and it doesn't impact the ability to care for other individuals who may have active symptoms and need more close monitoring that unit could provide. But if an individual has met the criteria for discontinuation of transmission-based precautions, then they do not need to be on a separate unit from the general resident population. Thanks.
Thank you, Namali.
Thank you. The next question is, I work in a COVID positive facility. We are providing N95 masks for our direct care staff along with all the other needed PPE. And the question is, what PPE should I provide to non-direct care staff, i.e. office, kitchen, etc.?
At the risk of not wanting to give an incorrect answer, I'm going to ask Namali to help with this one as well.
So, yeah, if I understand the question correctly, it's asking about people who are working on units or areas of the center that are not providing direct resident care, and we recommend, using universal source control with face masks or cloth face covering for folks that are everyone in the building, regardless of their role. So administrators and people in the kitchen, staff, dietary, and working on non-clinical areas. And so that, I think that was, hopefully I've answered the question. If I didn't, please let me know.
Thank you so much, Namali. We do have a question about the reuse of gowns, and any of our presenters or CDC can try to chime in on this one. Do we have any written guidance or any suggestions about the reuse of gowns or disposal of gowns?
This is Eli. I'll just chime in and say that there's a tremendous amount of resources on this on the CDC website about optimizing PPE supplies, and I can put that in the chat. It's a lot to cover, and I think in the remaining time, but the information is definitely covered in that CDC guidance.
Thank you, Eli.
Yeah, and this is Namali. Just to add one, was that Kara? Chiming in?
No, that was Angel. Go ahead, Namali.
Oh, sorry, Angel. I would just add to Eli's comment that we, when you're looking at crisis standards for use of gowns, we want to make sure people realize that the extended use idea where you could wear one gown during the care of more than one individual, which is a crisis standard, not best practice, is only something to be done on designated COVID care units where everyone on the unit is known to have COVID-19 infection. When you're working on units like quarantine or observation units where there's potential exposure, but the COVID status of an individual is unknown, we do not want our caregivers to, our staff to be using the same gown, moving from one person to the next. Thanks.
Namali, we had questions coming about this as well, and it's if it's the same suspected isolate. So if everyone in the unit has COVID, we understand, but if you have somebody that also has C. diff or MRSA, you're looking at a different concern there. Would you agree?
Absolutely. Thanks for that clarification, Eli. You're right. That only works if the only pathogen you're dealing with is COVID. If somebody has a co-infection with another pathogen that can be spread by contact, then you designate just that gown for that person's use and don't extend it.
Angel, we have time for one more question.
Okay, great. All right. Thank you, both Dr. Stone and Eli. So this question, and I'll pose it to anyone on the team. Do you have to use a gown in a suspected COVID-19 patient's room for non-contact procedures, such as giving medication?
So this is Deb, and I can answer that. I covered it in the presentation. For any suspected COVID-19 patient, you would need to have a gown and gloves on to enter the room, along with your mask and face shield. It's all PPE for COVID-19 because you don't know. They could have it. So that would be yes.
This is Kara.
Hey, this is Namali. I think, go ahead, Kara. Go. Yeah, we can hear you.
Oh, yes, thank you. Sorry, I've been trying to get off mute. So I completely agree. I think the one thing that may cause some confusion is that in our optimization guidance, when we talk about situations where it's a crisis situation and you have very, very limited keeping them for situations which are fading.
And Kara, you are fading out a bit.
No, can you hear me okay now?
Now, yes.
Okay, sorry. I will try to be brief, and I'm having some internet issues, I think. So what I was trying to say was that there may be some confusion that comes up with this question, because we have talked about in situations where it's crisis standards of care and you have very limited gowns, prioritizing the use of those gowns for high touch or prolonged touch activities. And so I wonder if that may play a role in the question, but that is correct, that if you have a person that is suspected of having COVID, a gown would be a part of that PPE that would be recommended for their care. It's just in that optimization of PPE, depending on where you're at in terms of you may make a decision to prioritize continuously updating or assessing your supply and your amount of supply, so that you can make decisions about what strategies you should be using in terms of optimization. Thanks.
Kara, thank you so much. And thank you to all of our presenters on the call and to all of the attendees. Next slide. So I just want to thank you for your participation in today's call. So we hope you found the information provided today valuable and on the topics that we discussed. Please take a moment to complete the survey from today's event. That will be posted in the post assessment, and it will also be included in the chat box. Thank you all for attending again, and this concludes our call for today.